Alrighty, Alexis, if you're ready to go, we're ready to hear from you.
Perfect. Thank you so much. And thank you everyone for joining today. So my name is Alexis. I'm a physician assistant. Just a little bit of background about me and how I got into radiation. I originally started my PA career working inpatient hematology oncology. I worked for 2 years in a hospital setting. I saw solid tumor patients as well as benign heme and some heme malignancies, including multiple myeloma and lymphoma patients. When I was looking to get out of the inpatient setting, I had one of my medical oncology attendings mention a job in radiation therapy. I knew very little about radiation. All I knew is probably what I hope and I assume most of you have as far as knowledge is the patients go to the basement to get their radiation and we count how many fractions until they're done with treatment. So it was a big learning curve for me, but I have found that APPs have a great role in radiation therapy and we can really provide a huge bridge to a gap in coverage there. So I'm hoping this lecture will give everyone some insight into what it is that we do in radiation therapy and what it takes to deliver these treatments for our patients. I focus more on kind of the radiation treatments themselves and the delivery. If anyone voices like interest in learning more about toxicities and side effects, I felt like that is just its own huge subset of things that could be addressed in a separate lecture in the future if there's interest. So in the interest of time, I'm going to get started with first talking about how does radiation work. So radiation therapy works by damaging the DNA cells and it destroys their ability to reproduce. So we don't point the beam at a tumor and the cells don't just explode into nothing. What we do is we damage the DNA. And this can be done directly by breaking the DNA strands themselves or indirectly by ionizing water molecules and creating free radicals, which then damage the DNA cells. So once the DNA is damaged, when the cell goes to replicate, it is unable to, and it goes through cell death. So both normal healthy cells as well as cancer cells are affected by radiation, but cancer cells are less able and have a decreased ability to repair the damage to the DNA, and they are more likely to die off faster than our healthy cells. Cells are most sensitive to radiation in the G2/M phase of the cell cycle, if we go back to our biology days. So cells that are replicating faster or more frequently, such as cancer cells, are more likely to be caught in this phase of the cell cycle to be irreparably damaged and then going into cell death. Based off of these concepts is how we then create fractionation schedules. So fractionation schedules aren't just this random, let's break it up into 30 treatments. What we're trying to do is complement the ability of our tissues to repair in between doses of radiation while also trying to hit these cancer cells in different parts of their cell cycle to promote the most amount of damage to the tumors themselves. So what a fractionation schedule does, it's not only the number of treatments that we're giving, but also the dose of radiation per treatment, as well as the interval between fractions. So most times you're going to be seeing daily treatments, but you could also see every other day treatment, or you could see twice a day treatments. And then another thing that we're measuring is how quickly over a span of time do they actually finish all of those treatments. So there's conventional fractionation. An example of that would be 35 fractions of radiation to a total dose of 70 gray. That would be a conventional fractionation for a head and neck cancer patient. Hypofractionation is going to be less fractions of radiation therapy than conventional treatment. So something like 5 fractions of radiation to a total dose of 30. Because it's a higher dose of radiation per treatment, we actually end up getting to a pretty biosimilar dose of radiation, even though the total dose isn't the same. And then on the flip side of hypofractionation, there's hyperfractionation, and these are meant to get tumors that are extra resistant to radiation therapy, so doing this in a twice-a-day kind of treatment. So treatment options. So external beam radiation therapy is the most common type of radiation, and this uses a linear accelerator to deliver the high energy photons to the target. So when you hear a patient got radiation therapy, 90% of the time they are talking about external beam radiation therapy. And then on top of that, they're most likely receiving photons. Most centers, it is photons that they are receiving. Another type of radiation they could receive that's also kind of common is electron setups. This is more superficial treatments if we're treating the skin. So it's not technically photons. Photons are, for the most part, X-rays. There's different types as well, but essentially people are getting X-ray radiation therapy. In addition to that, now you might hear other terms. So with technology advances, we've been able to use different techniques of how we deliver external beam radiation therapy. So everything used to be 2D. And if you think back to a lot of the toxicities and historical knowledge we know about radiation therapy, we're talking about 2D treatments. But these advances, such as 3D, have allowed us to give a more conformal dose to the tumor and treating in a 3D rather than a 2D plane, which gives us a lot more flexibility to target, but also avoiding the structures around it. Other terms you might hear would be IMRT. This is intensity modulated radiation therapy. The way I've heard physicians describe it to patients, it's almost like paint by color. So we are able to deliver different intensities of radiation to different parts of the body, all within the same plan. So the highest dose of radiation, we might be targeting directly at the tumor, but then it's going to be a lower dose of radiation in the area around it where there might be a high risk of microscopic cells being left behind, and then an even bigger margin around that, getting an even lower dose of radiation. IMRT also allows us to much more easily spare critical structures within the radiation field. So the most common example used is the parotid glands in head and neck treatment plans. We're able to kind of shape the dose of radiation off the parotid glands with the goal of decreasing side effects of dry mouth for long term. Other things you might hear would be image-guided radiation therapy, or that IGRT. So now we use cone beam CTs, which is kind of like a low quality CT scan. We take a small picture every day of the patient in the radiation room in their treatment position so that we can visualize the tumor and our target and make sure it's lining up with the original CT scan we're doing. So not only are we just lining them up by their tattoos anymore, we're also able to see internally that we're hitting our target with our treatments. So lots of advances that have allowed us to be more efficient as well as precise with our treatments. Other types of radiation therapy you might hear about is stereotactic radiosurgery, or SRS. Another term you might hear, same thing, just a different term for the same thing, would be SBRT, stereotactic body radiation therapy. If we're being picky, SRS is technically only to the brain and everything else is SBRT, but it's the same technology. And underneath that umbrella then falls Gamma Knife, which is a specific machine using SRS technique to treat brain metastases. So that is very specific to just CNS. And we can go in a little bit later in this lecture about what's unique about Gamma Knife. But stereotactic radiosurgery is using high-dose radiation in a few amount of fractions. It has to be 5 fractions or less. And we're able to use these to target down to the sub-millimeter. Because it's a high dose of radiation therapy per treatment, our targets have to be small as well to be able to safely deliver the radiation without causing too many toxicities with it. Other types of radiation that are less common, but you might hear about, one is proton therapy. There are proton centers throughout the country, none in West Virginia. The closest ones would be in Cleveland, Baltimore, Philadelphia. Proton centers use protons rather than photons to deliver radiation. This is good because photons have an entry dose and an exit dose of radiation therapy. So when we're targeting a type of spot within the body, say the lung, not only do we worry about what's in front of the tumor to get the radiation to it, but it also continues through the body past the tumor. So we have to worry about what's behind our target as well when we're shaping that radiation therapy. Proton therapy is heavier. So when it hits its target after a certain depth, it actually stops and there's no exit dose. So this is really great when you want to minimize the dose of radiation to the structures around it. Specifically, we think about tumors in the base of the skull, where we have to worry about the brain and the spinal cord behind it. And it's also great with pediatric patients. Difficulty with that, obviously, is the logistics of getting someone to a proton center. And then another thing that I wasn't going to touch much on, but being aware of brachytherapy. So brachytherapy is taking radiation internally rather than using a linear accelerator or an external source. We are taking the radiation internally into the body to deliver radiation. Benefit of this is there's no entry dose or exit dose. We're taking the radiation exactly to where we are trying to target. Downside is it's more invasive. We have to be able to get the catheter or the seeds to the target first. So that requires either being in the OR or some kind of invasive procedure. So we use catheters that will deliver the dose of radiation directly to the site of the catheter. This is often used with women's oncology or gyn-onc, or you might see seeds such as prostate. Or more historically, breast cancer as well. So what happens when a patient is referred to radiation oncology for radiation therapy? First, they see and meet with the radiation oncologist in a consult visit. At that consult visit, if radiation is recommended, we go over education and we go over the dose of radiation and the fractionation schedule we recommend. We then submit to insurance for authorization for their treatment. And once treatment is approved, we then schedule the patient for their simulation scan, which is a CT scan. I'm going to go more into what that entails in just a moment. Once their simulation scan is completed, those images are uploaded into our radiation planning programs, and our dosimetry team takes over and works with our radiation oncologists to design a radiation plan. Once the plan is approved and completed, it goes through a quality assurance checks to make sure that it is safe for delivery. And then the patient is able to start treatments. After treatments, patients follow up with the radiation oncology team, including myself, and we'll just go a little bit more into each of these steps now. So what is CT sim? So you might hear simulation scan, planning scan, CT, radiation CT scan, all sorts of different words are used. But what a simulation scan is a CT scan performed with the patient in the desired treatment position, because this is how we are going to recreate the patient every day for their radiation therapy delivery. So we know that we are targeting this same area every day. Some things to know about that would be is Gamma Knife is a little different, and instead of a CT scan, we use an MRI. So when patients come in for a Gamma Knife treatment, they receive an MRI that day for radiation planning purposes. There's a lot of different ways that we can do CT simulation. Sometimes before a scan is set up, we will refer them to a surgeon for fiducials to be placed to help us with visualization. So for example, the liver is really hard for us to visualize and target sometimes. So we might refer them to the GI team to place radiopaque fiducials so that we can see that easily on a CT scan so we know that what our target is. Other ones would be breast cancer patients who have had a lumpectomy. They have a radiopaque placed within the lumpectomy site to help us with our targeting of our radiation plan. So those are done prior to simulation. So patient comes in and we place them in the position we want to place them in. We will use a lot of different immobilization devices to mold and shape uniquely to the patient. And then that device can be used every day for their treatment going forward. These devices are specific to the radiation plan as well as the radiation facility. So the device that is made at Mary Bab Randolph Cancer Center unfortunately cannot be used at our UHC site down in Bridgeport. Also, if a patient is getting radiation a second time to a site, we can't use their old device. We have to use a new device. So different devices we use, I included a picture here. This is what a mask would look like for a head and neck cancer patient. So it starts as a flat board, we heat it up and it becomes pliable, and then we shape it to their head and neck using holes over the eyes and the mouth, and we pull away from the nose as well. Other ones we use is vacuum bags. So it's kind of like a bean bag. We suck the air out of it and it molds to the person's like abdomen or legs or arm. In areas that we can't immobilize, we'll also use either like tattooing or stickers to help us line the patient up on the table. So for example, lung cancer patients might get some stickers on their chest to help us kind of get close in range for their radiation. A lot of people freak out because sometimes the stickers wash off or fall off. Again, these are just guidance. Now with other technologies such as image guidance radiation, that is just one tool we're using to help deliver the radiation therapy. So not only are we worrying about externally having these patients line up for treatment, but we also have to make sure internally all the organs are as closely lined up as possible. So two different areas we think about would be the lungs. The lungs move. Patients need to breathe while they're getting treatment. So now we have technology that uses respiratory gating, and it actually measures the amount the tumor moves throughout the respiratory cycle and measures that. If there's a certain amount of movement, like a couple of millimeters outside of what we feel comfortable doing, what we'll do is respiratory gating therapy, where the machines only turn on and deliver radiation at a certain point in the radiation or in the respiratory pattern and turns off. So it will turn on during expiration, turns off during inspiration. So we train our patients to kind of breathe in a similar pattern the entire time using like counting in the head. Another one that we'll do is breath holds. So patients have to have a good performance status and be able to do this, but we'll just ask them to take a deep breath, hold for 10 seconds, beam goes on, and then we'll give them a break, let them exhale. So there's a lot of coaching through the treatments as well. Other areas that we worry about internally is going to be the abdomen, because the bowels move around. So specifically, our prostate cancer patients, there's a lot of different organs surrounding the prostate. So we ask these patients to come in with like a full bladder, because then the bladder fills up like a balloon and lifts off of the prostate, which allows us to minimize the dose to the bladder wall. Same thing, the rectum's right by the prostate. So we'll ask them to make sure that they've had a bowel movement that day to make sure that the rectal vault is empty, because then the walls will collapse on themselves, making it a smaller target and hopefully minimizing the dose of radiation to the bowel as well. So these are just different things we work with our patients on to try to recreate this as much as possible, so we're delivering radiation every day to our target site. In addition to that, sometimes the way we position patients, they often, will complain and be like, oh, putting my arms above my head is so uncomfortable, or doing this. The reason why we do the certain other uncomfortable positioning is because we're trying to minimize the dose to other organs in the body. So by raising the arms up out of the way, they are not within the radiation field, and we don't have to worry about delivering radiation to the arm or the depth of that. In addition, another example I give is radiation for our breast cancer patients. A lot of times we'll ask them to do a breath hold because by increasing the lungs and expanding them fully while delivering the dose of radiation, we move the heart even further away from our radiation target so that we're fully minimizing that dose of radiation to the heart. So lots of different tricks we use for the treatments. Moving on, what happens after simulation? I think this has always been everyone's biggest frustration of what is happening when we keep on saying there's no plan yet, there's no plan yet. Why is taking so long with radiation? This is where all of the safety and safety checks are being done. So our CT simulation scan gets uploaded into our radiation planning program. So we have a completely different EMR system. It's called ARIA, and this is where all of that radiation information is and why you guys see so little documentation from us like in things like Epic, because a lot of what we're doing is in a totally different site that helps us coordinate radiation delivery, planning, all of those things. So once the CT scans are uploaded into this program, our radiation oncologists receive it in their work queue. And what they're going to do is what's called treatment contouring. And what that is delineating out or drawing out what they're trying to target with the radiation therapy and saying what is the dose they want to do to that target. There's a couple terms that we use for that radiation, including GTV, CTV, and PTV. What those are is the gross tumor volume, the clinical treatment volume, and the planned treatment volume. So they measure out all of these things and instruct exactly the goal of what they want to do. In addition to contouring out what they're wanting to target, they also will delineate out what they are trying to minimize the dose to, or the organs at risk, OAR. So for example, I'll come back to this slide, but this is an example of contouring. So this is a head and neck radiation plan. You can see in the red dose is the highest dose of radiation. This is where the patient's tumor was sitting in the left oropharynx or left tonsillar region. So that's where our gross tumor volume is and our highest dose of radiation. But then we're going to do a smaller clinical treatment volume to the lymph nodes around that area. In addition to that, you can then see that we've also contoured out the mandible and the opposite lymph node chains with the goal of minimizing the dose of radiation to those to the mandible and other lymph node chains. So after the radiation oncologist gives all of his specific instructions or goals of treatment, it then goes to our dosimetrists who are trained in creating radiation plans using different software technology. So they will select the modality that we just kind of went over, 3D versus IMRT versus SRS. They'll choose the beam selection. And we'll make together a radiation plan and a radiation prescription that breaks down all of those different things we're using. In addition, this plan is then also going to have how much of the target is being covered, what is the dose being delivered to those organs of at risk, and this is kind of what we then have on our side. So you can see the gross disease in this patient's plan was receiving a VMAT plan with 6 volts of energy, getting 2 gray per fraction, total of 35 fractions, with 1 fraction a day, 5 fractions a week, and the total dose being 70. But then we had like the moderate risk getting a total dose of 60 gray, and then the lower risk disease getting 54 gray. In addition, this was image guidance, so they were getting a CT every day before treatment. It specifies that it'll be concurrent with chemotherapy, the goal of it. So we have all of this in our record systems. So once patient is done with the radiation plan, it goes to the radiation oncologist, and he approves the plan. The next step is it goes to our physicists, and our physicists are going to be doing the quality assurance or the safety checks. So this is done fairly quickly within 24 or 48 hours of the plan being completed. And what the physicists do is they check everything to make sure that we are giving safe doses of radiation to all the critical structures, as well as safety on the treatment machine, that this can be delivered feasibly on the machine without harming the patient. So once that passes safety checks, we then schedule the patient for treatment. So what is it like to receive radiation therapy? Radiation treatment vaults are these big rooms. So patients that are claustrophobic, these rooms are very large, very different from getting an MRI. A lot of times the radiation suites will have like nice things on the walls to look at. But it's like getting an x-ray is what I tell my patients. You don't feel the radiation. You don't see the radiation. If it's external beam radiation therapy, you're also not getting, you're not going to be radioactive after you leave the room. We have cameras and microphones in the treatment vaults so that you can, so that we can speak to the patient the entire time they're receiving their therapy. It is radiation therapists who are delivering the radiation itself. So these therapists have gone through additional schooling to be able to deliver radiation therapy. And these are the people that are seeing the patients every day. It is not, the radiation oncologist does not need to be at the machine every day to be delivering radiation. At times, they will be called specifically when a patient is starting radiation therapy, if they're getting a high dose of radiation, like they are with stereotactic radiosurgery, or if there is a concern with the lineup of the patient, they may be called to the machine to assess things prior to delivering a dose of radiation. But for the most part, it is just the radiation therapists that are working independently, delivering these treatments every day. So that's the other thing that I think I didn't understand prior to working radiation is I can go a whole week or even a week and a half sometimes without like seeing my patients necessarily if someone else has seen them. So it's sometimes hard to be seeing what's been going on with them or catching toxicities early. And we really rely on our radiation therapists and try to educate them on toxicities to monitor for. So what the radiation oncologists receive every day is those images we do at the machine. So they are checking off to make sure that they're happy with how the radiation plan is being delivered. And this can be done remotely on their computer. So they just need to be checking it. But what they do is they compare those images to the CT simulation image to make sure they're lining up appropriately. We do check in on our patients once a week at least, or at least once every 5 treatments. This is called their OTV visit or their on-treatment visit. So this is a quick nursing visit where we check in on toxicity management. This is performed by the radiation oncologist, but I will assist with it. And typically we try to see all of our patients on the same day just for logistical ease. So this is what machines look like. This is a linear accelerator. So you can see the arc and the beam. The radiation is going to be coming from this main treatment or main part of the machine. And then you can see a little bit of the treatment table here. The treatment table can go up and down, and it can even move like in different angles. So specific to Mary Bad Randolph Cancer Center facility, we have 3 machines and 3 treatment vaults right now. So this one is called TrueBeam. This can do like the respiration gated imaging that I was talking about. We can do SRS on this machine. And then like I was just saying, that table is also called the couch. And that is able to move around so that we can do these 3D plans and hit at different angles rather than like the traditional 2D version. This is another machine we have at Mary Bab. This is called Trilogy. Just so that you can kind of understand like what it looks like for a patient. As you can see, these are pretty big machines. It's well away from the patient. The room itself is very large that they're sitting in or lying down on. This one is different in that it has this 360-degree moving arm. So the arm of this machine can move around the patient. So they'll see it moving and they can hear actually when it's on and delivering the radiation. So if you ever hear a patient being like, oh yeah, I'm used to it going in these different angles and directions, this is kind of like what they're experiencing. And lastly, then I was going to go over a little bit about gamma knife radiosurgery. So the third treatment vault we have at Mary Bab is the gamma knife machine. What's different with this is that we have an active radioisotope cobalt within the machine. And what we are able to do is direct the cobalt, or what is being let off by the cobalt, which is gamma rays, and directs them towards our target. So you can see it's coming from many different angles and then conjoining on the target of the radiation therapy. So this is how we can treat a lesion that's deep within the brain without causing significant radiation toxicities to the surrounding structures prior to reaching the brain met by doing these tiny little doses and conjoining it all in one center. So patients for this, their immobilization device is this metal frame or like bird cage that goes around their head. And then there's 4 points of contact where they use screws that the neurosurgeon places in the OR while the patient is given sedation. And the screws then wedge up against the skull. It does not enter the skull, it goes up against the skull. And then it attaches to the frame. And this frame then, it has areas that can click into the machine or the table to hold the patient in place during the radiation therapy. But otherwise, it's wide open. You can see that their face is looking out of the treatment vault, so it's not as tight or small as an MRI machine is. So what happens when they're done with radiation therapy? This is when they come back. Standardly, we will schedule our patients to come back 1 month after radiation. As I said earlier today, radiation therapy itself to receive is painless. As a patient goes through radiation therapy, however, the toxicities will accumulate, and the most severe toxicities that a patient is going to experience are at the end of treatment or even the week or two following treatment. So for many patients that are actually getting a very high toxicity, treatment that's known to have a lot of high toxicity, such as like head and neck cancer, I often will bring them back even like 1 week or 2 weeks after treatment to check in on them and make sure they're doing okay. But otherwise, a lot of times we're bringing them back 1 month after radiation therapy. So we'll do both acute versus subacute toxicity checks and follow these patients for months later. The famous saying that everyone loves to say is radiation is the gift that keeps on giving. So there are many late toxicities associated with radiation therapy, and I do think it's important for our patients to keep following up with us to help with that survivorship and management associated with these radiation treatments. In addition to discussing their radiation toxicities and helping manage those, I'm also helping with oncology surveillance during these radiation follow-ups. So whether that is doing scans for surveillance or doing review of systems and physical exams, many radiation oncologists are able to perform scopes and be able to look in the upper airway digestive system for head and neck cancer surveillance. So we'll also order blood work, whether it's like PSA checks for prostate patients who receive definitive radiation. So those are the two things that we're doing with follow-ups. And our philosophy at Mary Bab, at least, is that these patients should be following with us for at least 5 years, if not a lifetime. I know other facilities do not always have the staffing to allow that. So some patients, if they're also following closely with medical oncology, may be discharged from radiation therapy, depending on their staffing abilities. So then the last part of this conversation I wanted to have is just kind of talking about things that are going on in the radiation field and other terms you might be having to hear. So we talked a little bit about proton therapy. Proton therapy is continuing to increase its effectiveness. I would say at the beginning of its like early days of proton therapy, they weren't able to get these great conformal plans that were able to deliver a conformal plan. So there would be like a lot of hot spots or so. And the technology wasn't really there, but they are able now to do these IMRT plans, just like photon therapy, and are getting quite good at treating these skull-based tumors. So it's definitely something you can always ask, hey, do you think this patient would be a good candidate for proton therapy? Especially if you're hearing from a radiation oncologist that it would be a very toxic treatment or hard to deliver based off of the site of the tumor. I often think about like intraorbital, or those that have like orbital involvement would be another good example of one that might be a good candidate for proton therapy. The other thing that we are not currently doing at our facility site, but certainly a lot of radiation oncology centers are starting to do more and more, is radiopharmaceuticals. So radiopharmaceuticals are going to be medications that have a radioactive component or a radioisotope in it that are helped to treat cancers. The most common one that I always talk about is Xofigo, which is used for diffuse metastatic bony disease and prostate cancer patients. There's a lot of logistics that go into delivering radiopharmaceuticals. You need to have a hot box room. So because you're administering something that's radioactive, you need a safe place to do that. So it's not like we could just have the patient go up to the infusion center at our cancer center and receive these drugs. There needs to be a safe place for them. They need to have their own bathroom. We need to be able to have the appropriate storage for these, as well as being able to get rid of any waste for them. So there's a lot of logistics to go into it. So I know these are future goals for WVU medicine to offer, but at this time we just do not have that here, and our nuclear medicine team is more equipped for that at this time. In addition to the delivery of it in the cancer centers, other things that you have to think about too then would be is patient education. So as I was saying, with external beam radiation therapy, all of these patients are, they do not have any active radiation in their body when they leave the treatment vault. So they are not radioactive. There's no restrictions as far as in their care. Or being able to be near general population. With radiopharmaceuticals, we do have to do additional patient education for this and patient safety. So those are just some of the things to think about when we think about how can we get these drugs more readily available for our patients. I went over a couple of the machines we have here at WVU at this time, but there's so many different variations of linear accelerators out there. And then there's new machines that are coming out with different technology. So there's two different types that are using, instead of CT guidance imaging, they are using MRI guidance. So this would be really nice, for example, when I was talking about like treating a liver metastases and how hard it is to see and delineate our targets on CT imaging. The thought is being able to do it with like an MRI would really allow us to be able to do that without having to put a patient through a procedure to have fiducials placed. This also would help with the logistics of treating, like, for example, brain metastases. A lot of times if we are treating a brain metastases that is not with the gamma knife, we are needing an MRI for planning purposes within a short window of time from the start of their treatment. And I'm sure, as many of us know, it's hard to get an MRI time slot right now in a reasonable time to be able to also treat the person. So these would be nice availabilities. There's also a machine out there that it's not FDA approved at this time and is only under research, but it's using PET imaging to help target radiation therapy. So the patient would receive almost like a low quality PET scan while on the treatment machine, and the radiation would target any of the PET-avid lesions that we identify. So this is something that might be able to be used in the future for patients with oligometastases and deliver radiation to all of their sites in one radiation plan. So kind of cool things to think about that are coming out. And then lastly, where I think a lot of research is going right now and questions that haven't been answered yet is our newest breakthrough with oncology that has been success has been our immunotherapies. And I don't know if we have fully mastered or figured out the best way to use immunotherapy in coordination with radiation therapy. I think we're learning that it can cause increased toxicities together. So how do we complement the two? Especially for those patients that maybe have had like oligometastases or might be having some early progression while on maintenance therapy. So I look forward to more of those clinical trials coming out and figuring out how we can maybe add immunotherapy in, for example, to cancers that are currently being treated definitively with radiation therapy, such as like head and neck cancers. Maybe we can use immunotherapy to escalate those high-risk patients. So that is the end of my presentation, and I'd be happy to hear from you guys on any questions that may have come up during this conversation, or maybe additional things that I didn't touch base on that you've been wondering about radiation.
Right. I didn't see any questions in the chat, so we're all good there. But if there are no other questions, I will go ahead and stop the recording.